Hey there, CyberMDs. Today we're going to be diving into a topic that is crucial for understanding heart failure. Before we dive into cardiomyopathies, please remember to like, comment, and or subscribe so that we can continue to provide free medical education resources for students all around the world. Let's get started. On this slide, I've listed a brief lecture overview. We're going to be going over the four major kinds of cardiomyopathies. The first is dilated cardiomyopathy. The next is concentric hypertrophy, which can be a type of cardiomyopathy. The next is HOCM, or hypertrophic obstructive cardiomyopathy. This is essentially an asymmetric concentric hypertrophy. And then lastly, we'll have a little bit of a lecture over restrictive cardiomyopathies. First, however, let's start with the basics. When we talk about cardiomyopathies, what are we really referring to? At its core, the term cardiomyopathy really describes mechanical diseases of the heart. Think of it as a broad umbrella term that's really encompassing various conditions where the heart doesn't function as it should. And remember that cardio means heart, myo is going to be referring to the myocardium, and the opathy portion of the word refers to the dysfunction or the presence of pathology. And so the name literally means heart muscle disease. So keep that in mind whenever we're discussing the cardiomyopathies. So what exactly does it mean when we say the heart doesn't function properly? Well, in the context of a cardiomyopathy, it means that there's something affecting the heart's ability to pump blood effectively or to relax and fill with blood properly. This can be due to structural changes, functional abnormalities, or both. Now, you might wonder what causes these abnormalities in the heart. The heart's a very resilient organ for the most part, but it's not immune to the stressors around it. There are numerous factors and conditions that can stress the heart. These include arrhythmias like atrial fibrillation. You can have myocardial infarctions or heart attacks. Infections that can reach the heart may be Chagas disease. Exposure to certain toxins such as alcohol can affect the heart and damage the myocardium. And then there are even autoimmune diseases that can affect the heart. Each of these stressors can impact the heart in its own special way, and the way in which it impacts the heart is important for how the pathology develops. And that's the key takeaway. It's not just the stressors that are important. It's the heart's response to those stressors that defines the specific type of cardiomyopathy. In other words, the way the heart reacts or adapts to those challenges determines the kind of mechanical disease that develops and the type of mechanical disease that we see. In the sections to come, we're going to dive a little bit deeper into those different types of cardiomyopathies. And so let's do that now with dilated cardiomyopathy. So, first up, dilated cardiomyopathy. At the heart of this condition, pun intended, are the heart's actin and myosin filaments. These are the primary components responsible for the heart's contractile function. Remember, we have that overlap, those myosin actin cross-bridging. Now, imagine that these filaments are being overstretched, much like an elastic band that's been pulled way too far. When this happens, the heart's ability to contract diminishes. Remember the Frank Starling mechanism from your Step 1 studies. Some extra stretch can really optimize that contraction force, but too much and you actually begin to lose contraction force. And so the result is going to be systolic heart failure. Remember, systolic refers to the contraction phase of the heart, and so in this condition, the heart struggles to contract efficiently and effectively. And specifically, we're talking about the ventricles of the heart. The ventricles aren't contracting efficiently or effectively. And so clinically, how does this manifest? Picture the heart not as a robust muscular organ anymore, but rather it becomes just this sack of blood, just this floppy bag, almost like a plastic grocery store bag. And so it's not pumping effectively, it's merely just holding the blood there, and it's not really moving anything forward. And when it does move it forward, it's certainly not using the force it should because, again, we have too much stretch. And therefore, you're going to get these heart failure symptoms, the shortness of breath, the edema, possibly the chest pain, the elevated JVP, which I have pictured here on this slide. And you may even see the hepatojugular reflux on physical exam. Now, we talked about the stretching and how that presents clinically, but what's causing that stretching, that subsequent dysfunction? There's a lot of different etiologies listed on the slide here, but typically for dilated cardiomyopathy, the etiology is idiopathic, meaning we don't know what causes it. These patients just present with it. However, sometimes we do know the cause. There's infectious agents. There's ischemia. Heart attacks can cause this. There's valvular diseases. This regurgitation can cause this dilated cardiomyopathy. Maybe patients have problems with alcohol abuse, and that toxin causes the heart to become dilated, and they get this cardiomyopathy, as well as infectious agents. I mentioned Chagas disease earlier. We can see that sometimes in our patients, especially if they come into the United States and they've immigrated here and they don't have this diagnosis earlier in life. That is a potential etiology that you can see in a clinical setting. So now that we understand all these various things can lead to a dilated cardiomyopathy, the question is, how do we make the diagnosis definitively? And so the answer is going to be with an echocardiogram. Remember, you might be tempted on an exam to pick a chest x-ray, and remember, on that chest x-ray you might see a dilated cardiac silhouette. However, that's not really sensitive or specific enough to make the diagnosis. If you investigate the heart with an echocardiogram, you'd observe the dilated ventricles, the poor systolic function, and that would really confirm the diagnosis for you. On this slide here, I've had playing on the bottom left of the two images, you can see a heart with normal function. And then on the upper right of the two images, you can actually see a heart in which the left ventricle is actually dilated and it's squeezing very, very poorly. And so right here is this dilated ventricle. This is the left ventricle on an echocardiogram, and it's very dilated. You can see it's not squeezing at all, whereas this one, these muscles are coming in, they're touching right here, and then this portion of the mitral valve right here actually comes out and essentially like touches this wall of the interventricular septum right here, because this is the right ventricle up here, and again, right ventricle up here. So you can make this diagnosis on echocardiogram, and that's what you're kind of looking for, is this very dilated left ventricle with very poor systolic function. And so now that we've made the diagnosis using an echocardiogram, the question becomes, of course, what do we want to do for this patient? So this patient is going to come in probably with an acute exacerbation of their heart failure, and we're going to treat them with the LMNOP, and then chronically, right here, this LMNOP, and then chronically, we're going to treat them with the ABDs of heart failure. We're going to use guideline-directed medical therapy, and if it's severe enough in the long term, they might receive an ICD or an LVAD, which is this mechanical pump that essentially it's a left ventricular assist device, so it's kind of a mechanical pump that helps the left ventricle, and they might even get a heart transplant if it's severe enough. And so I really encourage you to watch the heart failure lecture after this one to really understand how the LMNOP and the ABD's approach helps our patients in heart failure, whether it's acute exacerbations for the LMNOP or chronic treatment for the ABDs. All right, moving on to the next cardiomyopathy, which is concentric hypertrophy. So concentric hypertrophy is going to be characterized by an increase in the thickness of the heart wall itself. And again, it's going to be concentric, so all the way around, and that means it's symmetric all the way around. And that's really important for differentiating concentric hypertrophy from HOCM. Especially on an exam, they may word things in such a way, the answer choices in such a way, that would lead you to pick an answer choice that actually meant HOCM versus concentric hypertrophy. So it's very important to remember this difference. Concentric hypertrophy is symmetric hypertrophy, and that's in regards to the musculature of the left ventricle. And so the primary driver is going to be an increased workload on the heart. So that's really going to drive this pathology, and that's often going to stem from something such as hypertension or aortic stenosis. Anything that really increases the afterload on the left ventricle can lead to this concentric hypertrophy. And so you can just imagine the heart as a muscle, which it is, but imagine it's just constantly lifting weights. It's constantly having to work against this extra pressure. And so it's going to grow a little bit thicker, just like if I went to the gym and all I did all day was a bunch of bicep curls, eventually I would get a really big bicep. And so it's essentially going to do the same exact thing. It's going to hypertrophy, it's going to get thicker to work against that afterload that I mentioned earlier. And so also it's very important to note that this is hypertrophy and not hyperplasia. Those are two very different things. Remember that from step 1 studying. This is hypertrophy, in which the musculature gets larger, and this is not hyperplasia, which is when more cells or the cells divide and become more numerous. And so clinically, again, what does this mean? So a heart with concentric hypertrophy can lead to what we call diastolic dysfunction. Remember, in dilated cardiomyopathy, previously we were talking about systolic dysfunction. Now we're going to be talking about diastolic dysfunction, meaning the heart struggles to relax and it struggles to fill with blood properly during the diastolic phase for the ventricles. And so imagine that really thick, really strong left ventricle with all its musculature that is very adapted and so used to being flexed against that afterload that it just becomes so tense that it has trouble relaxing. And so for this, I kind of think about those bodybuilders whose arms, whenever they're relaxed down at their side, they're still flexed a little bit because that muscle is so used to being tense that they actually have kind of this certain amount of tension at rest. And that's the same thing that's occurring here for all intents and purposes. And so if this is left unchecked, this diastolic dysfunction can progress to heart failure as well, because now we can squeeze the blood out, but there's not enough blood squeezing out. And so the primary culprits behind this concentric hypertrophy include, again, chronic hypertension and chronic aortic stenosis. Both of those conditions increase that afterload and the resistance that the heart has to overcome in order to eject blood. And I wanted to take a second and give you a memory hook to remember that aortic stenosis makes you SAD, S-A-D. Patients with aortic stenosis can have syncope, angina, and dyspnea, and they occur in reverse order from what I just said. So typically patients with aortic stenosis get shortness of breath first, then they will get chest pain or angina, and then they will start having syncopal episodes. It's just a very useful mnemonic that I've found really helped me throughout my studies, and so I wanted to make sure I shared that with you and made a point to emphasize that. And so similarly with all of these cardiomyopathies, how are we going to diagnose this? We're going to use echocardiography. And so what you would see on an echo is you would see the heart walls that are thickened, but the chambers themselves, remember, aren't dilated. That chamber is actually going to be a little bit smaller, but the thickness is all the way around the left ventricle, not just in one part. Remember, this is concentric hypertrophy. It's symmetric. So if you get like a parasternal short view of the heart where you just see the right ventricle and left ventricle, you would see the thickened myocardium equally all the way around symmetrically. And so we've made this diagnosis now with echocardiography of concentric hypertrophy. So what do we do about it? Remember, first of all, we should always try to address the underlying root cause of a pathology or a presentation. And so if hypertension is the culprit, we should try to control the patient's blood pressure. And so medications that can be used there are going to be your ACE inhibitors, your ARBs, your beta blockers. Those are going to be all very commonly prescribed things that can try and help prevent any further cardiac remodeling. And so those are not only going to help control the blood pressure, but again, that's going to have long-term effects on the structure and function of the heart. And then again, if this is severe enough, a patient may need a transplant. I went ahead and put calcium channel blockers as well. They're not first-line agents, but they are sometimes used if there are other contraindications to ACE inhibitors, angiotensin receptor blockers, beta blockers for whatever reason, and the patient needs calcium channel blockers. Remember, those two can help us get the proper relaxation that we need and can also help to reduce the blood pressure. And so those are going to be another option for medications in patients, just not typically used first line. All right, now let's discuss hypertrophic obstructive cardiomyopathy, sometimes referred to as HOCM. HOCM is primarily going to be caused by this autosomal dominant mutation in the genes for the myocyte sarcomeres. And so the question becomes, what does this mean for the structure of the heart? Because we're talking about cardiomyopathies. So it's going to lead to an asymmetric hypertrophy. Remember, we just talked about concentric hypertrophy, which was symmetric. Now, this is going to cause an asymmetric hypertrophy, specifically of the septal wall, the interventricular septal wall. And so instead of the heart thickening uniformly, one part, again, that interventricular septum, thickens more than the rest. And that thickening can cause an obstruction of the aortic outflow tract, which is going to have pretty significant implications for blood flow and overall heart function. And so the presentation can be a little bit deceptive. It's often pretty similar to aortic stenosis because, again, you're kind of obstructing this outflow tract, but there is a key difference. Or multiple key differences, really. The murmur for aortic stenosis is typically best heard at the upper right sternal border, but the murmur for HOCM is going to be heard best most likely around the apex. And so another distinguishing feature, I said there were going to be multiple, is that HOCM is going to typically be in very young patients. This typically is seen in young males, especially athletes. Sometimes they have sudden cardiac death, which we'll talk about. And then your aortic stenosis patients are typically going to be older patients who have had a lot of damage to the aortic valve over time, and they have those calcifications and therefore that stenosis. And so think about those kind of differences. Where is the murmur at, as well as who is this patient? What kind of population do they belong to? And that can kind of lead you one way or another in terms of diagnosing for aortic stenosis versus HOCM based off of presentation and physical exam. And so these patients with HOCM might present with shortness of breath. They might present with chest pain. They might have syncope. This is something to think about in your patients with syncope is HOCM, especially, again, if they're in the right patient population, those young adult males. And then also patients who have sudden cardiac death, especially otherwise young and healthy male athletes. This is kind of one of those common causes of sudden cardiac death in those patients. So if the patient were to die on the field playing a sport or on the court playing a sport, this would be something to consider in your differential diagnosis for that patient. So remember again that this is going to be due to that genetic and autosomal dominant gene mutation that's affecting those myocyte sarcomeres. And so here again, I've provided some ultrasound images which we will review, and again, echocardiogram or transthoracic ultrasound is going to be the best mechanism for diagnosis. And here again, we have these parasternal, what we call parasternal long views of the heart on ultrasound that would be very definitive in making this diagnosis. And so you can see on the bottom left, we have the heart here. This is the left ventricle right here, and this is the ultrasound image of a patient who has HOCM. And you can see this is the interventricular septum with a very small right ventricle up here, and this interventricular septum is much more thick than this area down here, and it's impeding upon this outflow tract here, because this is going to be aortic outflow tract, and this is going to be your left atria. So we have left atria into the left ventricle with an impedance of our aortic outflow tract. And that's going to be in contrast to a normal functioning heart up here. We can see we have a nice normal sized chamber. We have a normal sized right ventricle. The thickness of the interventricular septum is roughly the same as this other side of our left ventricle over here. And so there is no pathology going on here. And so compare and contrast these images to sort of get a better understanding of what a patient with HOCM would look like whenever you took an ultrasound and placed it on their chest to make this diagnosis. And so one other thing I wanted to talk about is something called the SAM effect. And the SAM effect stands for systolic anterior motion, and that's specifically in regards to the anterior mitral valve leaflet. So essentially what happens is this hypertrophied septum that I pointed out is going to narrow that outflow tract. And so during systole, the blood that's being pushed through that very narrowed lumen is going to be traveling at a very high velocity. And that's going to create something called the Venturi effect, which is a physics phenomenon essentially. And that's going to drag or pull that anterior mitral valve leaflet towards the septum whenever it's supposed to be closed. And so you may get some regurgitation, and you get this, again, what we call SAM effect, or systolic anterior motion of the anterior mitral valve leaflet. And so that's something to keep in mind, something they may describe on an exam, or clinically something that you can describe and see and measure on ultrasound. And so you can see that with Doppler echo, again, as a jet of blood flowing back into the left atrium if there's regurgitation, and you can just see it whenever it's in systole, the ventricle's in systole, and it's pulling that anterior mitral valve gets pulled up towards the septum. So it's just something I wanted you to be aware of. I think it's unlikely that you would be tested on this, but I do think it's possible, and I wanted to make sure you were aware of it. So now let's finish talking about HOCM with the different treatment strategies. So first and foremost, you want to make sure that these patients maintain adequate hydration, because that's going to expand that left ventricle and give them enough preload to where it doesn't the interventricular septum doesn't completely obstruct that outflow tract. So dehydration can actually exacerbate the obstruction and worsen those symptoms. And that's going to be very similar to what we discuss with our patients with concentric hypertrophy. And additionally, you can give them beta blockers or calcium channel blockers. Beta blockers are essentially a mainstay of treatment for these patients to kind of reduce that cardiac remodeling over time. However, if there is very severe obstruction and this has progressed a long time before it's found, they may need something called a myectomy, where you actually go in and they will remove some of that extra heart tissue there. And then these patients, if they have severe heart failure from this, they may also get an ICD, they may get transplant, and they may get screening for all their first degree relatives, because again, this is an autosomal dominant mutation. And so you can also see, I haven't mentioned it, but this septal ablation. And so you can imagine that as this interventricular septum grows and grows, there are parts of the heart's conduction system running through there. And so you may get aberrant conductions through those systems due to that stretching. And so they may need ablations as well if there are some sort of aberrant conductions due to the pathology itself. So another thing to keep in mind as a potential treatment for these patients. All right, on to the last cardiomyopathy for this lecture, which is going to be restrictive cardiomyopathy. So first, let's discuss the mechanism behind restrictive cardiomyopathy. Much like concentric hypertrophy leading to diastolic dysfunction, restrictive cardiomyopathy is going to be defined as a state in which the left ventricle has again become stiff, and so it has difficulty filling, difficulty relaxing. Therefore, the heart's going to face these difficulties in the diastolic phase. I really want to emphasize this is stiff ventricle, diastolic dysfunction, difficulty filling with blood. Therefore, there's not enough blood to pump out. And so again, that stiffness prevents the heart from accepting blood. So this obstructions, or maybe like junk inside of the myocardium, there's going to be like obstructions or junk, and that's really going to lead to this inability to relax for the heart. These patients are going to present with classic heart failure symptoms. So again, the shortness of breath, the edema, maybe chest pain. However, there's going to be other symptoms associated with the etiology of their restrictive heart failure that are probably going to be present. And that's really going to help you nail down the diagnosis and get the correct answer on an exam. However, it's really going to let you optimize your treatment for patients clinically. So you might wonder what causes that junk or that obstruction in the myocardium, and that's going to bring us to the etiologies of restrictive cardiomyopathy. And there's several culprits. One could be amyloidosis, and where there's these protein deposits accumulating inside of the heart tissue. And these patients may also have signs or symptoms of neuropathy or GI issues. You could also have a patient who has sarcoidosis, and so they have these systemic granulomatosis disease that can affect all kinds of different organs. Classically, it's going to include the heart and the lungs, and so you'll see that these patients have this restrictive cardiomyopathy pattern, but they also have this simultaneous pulmonary disease. Another popular one to talk about is hemochromatosis. So they have all of these excess iron deposits in the heart, and that's classically going to present in patients who also have maybe some cirrhosis and diabetes. Maybe they have that. I believe this is also the pathology with the bronze-colored skin. So look out for those kinds of signs of other etiologies. You can also have cancer if the cancer infiltrates the heart, if there are metastases to the heart. You can also have fibrosis for various reasons, including radiation exposure. And then those are all going to be some of these primary causes of a restrictive cardiomyopathy. But remember, there's going to be some other rare causes. This isn't a full in-depth lecture on restrictive cardiomyopathy. I really just wanted to hit some of these high points and help you to keep those in mind on your exam and in the clinic when you're seeing these patients. So restrictive cardiomyopathy, again, is going to be diagnosed the same way as our cardiomyopathies all have been diagnosed, and that's with echocardiogram or this transthoracic ultrasound. That may be another way that this is worded on an exam. So they may give you the diagnosis on the exam. However, you will also need to be looking for other diagnostic options to really help you nail down the etiology. So if you suspect amyloidosis, that patient, in addition to their echocardiogram, may need a fat pad biopsy, which is typically going to come from their abdomen or their rectal area. If you suspect sarcoidosis as the underlying etiology for their restrictive cardiomyopathy, they might need a biopsy, typically from a lymph node or skin or lung, and they'll also need a cardiac MRI. And then if you suspect hemochromatosis, you should maybe obtain a ferritin level, and then subsequently they would need genetic testing, and that would all be in addition to diagnosing them with the restrictive cardiomyopathy based on an echocardiogram. And so, again, now that we've diagnosed this patient, what do we want to do about it? What are our treatment strategies? And so, again, we're going to address the underlying etiology. So treat that amyloidosis, the sarcoidosis, the hemochromatosis, whatever that other underlying etiology is, treat that. But then again, maintain an adequate preload. Give them that stretch they need to really increase their Frank-Starling mechanism and help them pump blood effectively and help them fill those chambers effectively. We can provide beta blockers and calcium channel blockers, help prevent that remodeling with the beta blockers, and also really help to decrease the workload that the heart has, and then also help the heart to relax a little bit, increase that filling time, increase that preload that I've been discussing. And then these patients, if they are volume overloaded, you should be very gentle when you're diuresing them. So like it says on the slide, easy does it with these patients when it comes to diuresis if they're in an exacerbation. You don't want to overdo it and then take away all their preload and then send them into a tailspin the other way. So you're playing with this really delicate balance in these patients. And then in very severe or refractory cases, you can have patients who will need, of course, a heart transplant. And you would need to get them on the heart transplant list and make sure that they're following all the recommendations to stay on the heart transplant list to stay eligible. Okay, that's it, you guys. Thanks for tuning in to this lecture over cardiomyopathies. Again, please remember to like, comment, and/or subscribe so that we can continue to provide free medical education resources for students all around the world. Additionally, please feel free to leave us any comments, any feedback, so that we can continue to improve and make this as useful as possible for everyone out there. Thanks so much.